Hi, this is Jennifer Marquez, and this is my concept application project, Healthcare Delivery. Today I'm going to talk about the microsystem of the ICU and what the goals of the microsystem in the ICU are. So we have a multidisciplinary approach, we are patient family-centered care, we have a closed intensivist-led team, and nurse-coordinated patient care. Multidisciplinary approach means many different clinicians from all areas of the hospital come together to provide the best care for the patient. ICU is unique in that many times the patient is unable to express needs, and families are often the ones left making the important decisions. We're a closed unit because the intensivist takes over for the primary care physician and/or the hospitalists when the patient arrives to the unit. Nurse leads the interdisciplinary rounding and evaluation of treatment plan and adjusts and coordinates care. Goals of effective leadership in the ICU would be that you encourage staff development, you stimulate motivation, you have a team-based approach, you show emotional intelligence, and you support job satisfaction. Spano, Seekley, and Quinn Griffin explain emotional intelligence and transformational leadership, and we'll build on that for this slide. By encouraging and acknowledging of staff for teamwork, that stimulates job satisfaction. We have caring hearts on our unit, then we give them out to a team member who's done an excellent job. Then leaders are expected to provide feedback from daily rounding. Was the family and physician happy with your care? This encouragement and feedback is used to better our practice and give you a boost when you've done well. Provides valuable feedback to learn what we could have done better also. They are involved in daily and shift rounding, evaluation of the care completed, and putting the right nurse with the right patient. Was infection control practiced? What went well over the last 24 hours? And what can we change? They also manage conflict and utilize the team to find resolutions. They work to involve staff to find innovative solutions to conflicts through meetings and committees and conflict resolution. They provide a voice for the microsystem to the macrosystem. Through meetings and speaking with staff leaders, they are responsible for improvement across the microsystem. How does the organization meet goals? How does the organization support the microsystem of the ICU? Well, with clear expectations, a good work experience, organizational workings, and organizational learning. The organization provides clear expectations of goals for our ICU patient population, decreasing hospital-acquired infection rates. Due to the nature of the ICU, our patients are at a higher risk because of all the invasive procedures and equipment that we use to save their lives. Organization can identify staff who need improvement and provide ongoing education and sessions to keep up skills levels and practice procedures. Organization wants to improve on patient and staff experiences. How can we improve this critical time in a patient and family's life? How can we keep staff engaged and prevent burnout? By including patients and families in the plan of care and interdisciplinary rounding, clear patient and staff goals can be met daily. In our facility, daily rounding starts at 9 a.m. and includes the nurse manager, charge nurse, primary nurse, intensivist, pharmacist, nutritionist, case managers, consulting physicians, family, and may also include advanced illness management or the chaplain for end-of-life care. For staff experiences, consistent evaluation of what is working and what is not working in the unit. Recently in our unit, we had a supply door that was locked and the key was locked up next to it. Big problem in the ICU when you have a patient that is crashing and you need some supplies. Our organization heard our complaint and changed the door lock to a badge scan. Improving processes and workflow equals happy nurses. Organizational working is across the organization by implementing of policies and procedures and also ensuring that they are updated as needed. It is important to keep up with the latest evidence-based practices like the newest sepsis bundles. Hospital-wide education and latest technological and procedural practices can improve patient outcomes. It is important for other microsystems within the organization to be learning and to identify sepsis patients and recognizing the need for a higher level of care. Rapid response teams, sepsis and cardiac activation, stroke teams, and code teams are all used to provide quick assessments and interventions, but these practices will not be effective without organizational-wide learning activities. The culture of the organization includes what is important to the organization. How can we meet the values and the mission of this organization? We focus on patient and family-centered care in the ICU with a holistic approach, and we expect patient engagement. And then we often evaluate how can the ICU team maintain patient and family-centered care, and how do we develop staff improvement. A holistic approach is what we as nurses do. We depend on one another and look at the whole patient, all their medical conditions, each body system dependent on the other, and the patient's cultural beliefs, their fears, their expectations, providing education and resources and support for in the hospital and beyond. Acceptance of what the patient needs and making that the focus. Does the patient want everything done to save their lives? And making sure that they're aware exactly what everything means. There have been times in practice where a patient and family agree that they may not want extensive life-saving surgery, and we as caregivers are there to give them the best care they can get and fully inform them of their outcomes. Other times we may feel the patient is at end of life and quality matters, not quantity, but that is made their decision and the choice that they have to make. As nurses, we're constantly working to improve our care, improve our practice, improve our education. Nursing is constantly changing. As staff, we must have a high level of open-mindedness for opportunities. Our organization offers many educational opportunities throughout the last year. Our unit was invited to a large cardiology conference, a CCRN review course, advanced EKG training, and hospital practices monthly on different code situations in the hospital, all to improve staff, which in turn improves patient outcomes. Interdependence of the care team. Relationships are built on trust. Patient and family trust you, trusting your fellow nurses, physician and nurse trust. Rena, and Rushton brilliantly describe the trusting relationships of collaborative team in their article, Trust, the Foundation for Team Collaboration and Healthy Work Environments. Patients and families must find a level of trust for doctors and nurses. They trust us to be up on the latest approach to care and the latest advanced medications and practices to provide the best care for them. In the ICU, you have to be able to trust the nurse who's standing next to you in intense situations. We rely heavily on one another in life or death situations. If you can't trust your fellow nurses to help you care for your patient in trouble, you can find yourself overwhelmed and in a bad situation. You must also be able to point out things that went wrong and what needs improvement, as well as what went well with a certain situation. Having the ability to accept criticism and feedback is all part of being a good team member. As nurses, our whole profession depends on trust. Nurses and doctors in the intensive care require a higher level of trust. We must trust them in making the best care decisions, and they must trust us to fulfill their plan of care, and each dependent upon one another. This level of trust fosters a unique relationship that the nurse can act autonomously and question things that may not be right for the patient. We're held to a different level of trust in that the doctor trusts us to recognize complications or deteriorations in a patient and act accordingly. As nurses, we are at the bedside 24 hours a day, and a trusting relationship is a necessity. Electronic medical records and the newest technological equipment. In the ICU, newest technological equipment is very important, and the electronic medical records have the ease of shared information. We also have life-saving medical equipment and procedures. EMR, CPOE, and practice partners improved healthcare and shared information tenfold. The ease of transfer of health information continues to improve patient-centered care and decrease medical expenses for the patient and organization. In the ICU, we have the newest monitoring systems such as Spacelab's bedside monitoring. We can closely monitor every second of the patient's stay and see the information at the bedside, in the nurse's station, and in the hallways. We can see many hemodynamic parameters continually and set alarms based on the goal of the patient as an individual. With the use of health information technology, our patient's hemodynamic parameters are transferred seamlessly from the bedside to the chart. This information can easily be seen across disciplinaries to coordinate a patient-specific plan of care. With technologies like hypothermic protocol and Arctic Sun, post-cardiac arrest mortality rates are improving. We're giving our patients a fighting chance in an otherwise losing battle. Like many other ICUs, we've started utilizing a less invasive monitoring system for monitoring cardiac outputs, stroke volumes, systemic vascular resistance, and oximetry levels, with the use of transduced fiber optic central line and arterial line in the management of patients with severe sepsis and septic shock. What is our process for healthcare delivery improvement? Currently, we have an ICU committee, and we use a clinical nurse specialist. We have monthly meetings to evaluate staff, procedures, practices. The committee meets monthly with the intensivist, nurse manager, clinical nurse specialist, leaders of the ICU, and organizational leaders. Quality assurance nurses, and infection control all come together and evaluate specific patient outcomes and provide accountability of doctors, nurses, and organization based on performance level. Was a core measure followed? Were all treatment options explored? Also finding weak spots in policies and procedures. Currently, we're meeting about sepsis and improving this patient population. Did a repeat lactic acid get missed? Were the bundles followed and the feedback with rationale explored? With the integration of the CNS, performance levels and practices are improved upon. By evaluation and plan specific educational or ongoing practices of procedures, our care has improved. Our CNS can evaluate how we are preventing VAP by monitoring nurses and RTs. Our CNS is evaluating our code blues. How do we do compressions, meds, ACLS? Are we following the guidelines? By watching this process, she makes adjustments and provides practice and learning opportunities to better our skills and improve our patient outcomes. Staff performance patterns. We use staff evaluations, process review, multi-source feedback, and rating scales. We have 4 levels of multi-source feedback: the manager, physicians, the team, and self. Our performance on communication includes with the patients, families, physicians, and team members. Is the nurse proactive and effectively communicating needs and values of the patient? Were the patient's experiences and interactions good with the nurse? Are communications clear? Does the nurse paint a clear, concise picture of what's happening with the specific patient? Or does the physician often have to pull the information out of him or her, which could lead to a loss of information and possibly harm the patient? Does the staff member need extra education? Does a team member get involved and excited about new technologies or latest treatments? Are they involved with improving protocols and designing of protocols to improve outcomes or workflow? Is the team member someone you can trust? Are they a team player? This can be as simple as answering a call light, assisting a family member, checking on a beeping IV, or as complex as when your patient is coding. Can you count on them to be your partner and dive in? Each of these are equally important to the care in the ICU. The evaluations are based on a number scale, 1 through 4, including 1 not meeting goals and up to 4 excellent achievements. Can we improve our current healthcare technologies? This would be proved to have improved workflow for nurses, faster, accurate care for patients, and improvement of CPOE. While electronic medical charting has improved patient safety, the program that we use is not user-friendly as it should be. This causes frustration among care providers. Lab tests and other results are jumbled up, and if you're not careful, you could be looking at the wrong result from days ago. The computer program doesn't work well with, our IV pumps and our EMR, medication administration. You could hang a bag of fluid and it could seamlessly upload if it was, working to help the workflow for nurses based on the dosage and the amount prescribed. With improvements, we'd be able to share education with patients from the bedside with the click of a button. Currently, it takes navigation around 3 different systems to address specific needs of the patient. And CPOE, when it's working and the physician can find the treatment or medication he's looking for, it cuts the workflow in half. The problem is if the medication or treatment is not found in the system and the doctor resorts back to writing paper orders, which can be missed or never processed, and treatment gets delayed, treatment is never completed. Another problem is that the doctor slips the order in the chart without going over it with the nurse, and when she sees it, she realizes it's illegible and treatment is once again delayed. So how do we fix this problem? We utilize nurses who are proficient with computers. We encourage health information technology specialists to make monthly rounds and find out what's working and what's not. We make changes to the program quickly, and we meet with the program design specialist periodically. We search out nurses that are proficient with computers and advanced technology and build a team of nurses around them to make rounds to staff nurses and hear their requests, find out what's working, find out what's not. Healthcare is always growing and our technology must not get stagnant. Get the physicians away from writing doctor's orders and provide special attention to those who feel that they have no other choice. Find the root cause and work to quickly fix the problem. Meeting with the design specialists will only bring about changes if bedside nurses are involved and need a place in these meetings. They can meet till they're blue in the face. It won't matter if they are not the ones utilizing the software day in and day out. In conclusion, healthcare is a complex system with many moving